already. I'm with the Arkansas Center for Health Improvement. My title is Director of Information Systems Architecture, but I'm the APCD Director here. I am joined by Dr. Nicole Sanders and Mike Motley, also from ACHI. They lead the ACHI analytic team, and Nicole has a speaking role in one of the topics we're going to discuss today. Next slide, please, Kathy. So you saw the agenda 2 slides back. The first 3 bullets under topics, those are the subjects we're going to discuss today. We got these ideas from you, from people who filled out the survey last users group. We select our topics through the survey and through direct input from analysts that we interact with, and also from the APCD team who builds the data. We often find things that need to be addressed that the data users should know. So the first topic today is entitled Service Location and Member Location, Their Relationship. And I'm going to turn this over to Nicole because her work with the APCD is extensive, and she has encountered these challenges quite often. Nicole?
Oh, hey, I don't know why that is my background, so I'm just going to take that off.
Okay.
Okay. So a lot of people want to use service provider information to, determine network adequacy, utilization based on certain providers, provider locations, and in some cases, we've actually looked at the scope of work for certain types of providers and seeing where there may be, network adequacy is kind of the same thing, if there's a deficit in some areas. So in the DSG, and Kinley can correct me if I'm wrong in what I'm about to say, we've asked submitters to identify the service provider in the fields that we'll define or share with you guys in a minute, that it should be the entity that actually rendered or the attending provider that actually did the service. Unfortunately, that is not always the case, but you may not realize that until you're actually digging into the data. And it might be that a submitter doesn't realize that they're doing it that way. There's no telling with submitters. Submitters are required to populate the field. And then, yes, like I said, so it's either the professional, as I say, the human behind the service, or perhaps in like facility claims, it could be the hospital or the clinic service provider. Okay, next slide. So obviously the service provider information is in the medical claims data or the pharmacy claims data. And let me say something briefly on the pharmacy claims. You're going to find where the pharmacy, what the provider would be the pharmacy in the pharmacy location in that situation. So sometimes you want to see where members live and what service providers they're using, and if they're near each other, or if members are having to travel a ways away to get their services, and the types of services that might be associated with that. So you need to be able to relate your member location with the service provider. And the fields that you use and the tables that you use can be dependent upon your study question. So it's going to be dependent on how what your objective is for identifying service provider location. And then do you want to use the member location information that's provided on the claim, or do you want to use what's in the medical claim record? Or, I'm sorry, in the enrollment record. Yeah, in the member table. And again, those two things, like your decision point there is really depending on what you're trying to answer. And yeah, and also what it could depend upon is the time frame. I mean, there's multiple things that go into the factor into your decision for using the member table versus the member information on the claims. Okay. So in the claims, the service provider fields are listed here. You have the NPI. You have either the first, middle, and last name, or if it's an organization like a clinic or a hospital, MC028 and MC029 should be empty, and MC030 should be the name of the entity. You also have the address, city, state, and zip code. I think some subscriptions have zip 3 versus zip 5.
I don't think so on service provider data. You can get the full.
Oh, just member table. Okay, sorry about that.
Oh.
And then let's see. And you can find provider information or more provider information in the APCD provider table or in the NPI data sources like the MPPS and the links there at the bottom, or from other vendors who have created NPI tables. Okay.
I'm going to interject. Wait, go back 1 second, Kathy. Sorry. So you'll see in that asterisk commented below a particular data source called CarePrecise, and it is a pretty good compilation of NPI data from the MPPS website in a relational format. It's not terribly expensive, and we refresh it once a year. So if you have the budget, it might be something that you can invest in. Thank you, Kathy.
Okay, so let's look at the information that is in both the member table, well, in either the member table or claim records or both for the member. So you obviously get your member ID, that's ME107 and MC137 in the enrollment and claims. You have gender in both, and you have birth year in both. In both, you have the zip 3, the state, and the service. Oh, sorry. Then you have in enrollment, you have the enrollment and disenrollment dates and county, which is important for some studies. And then in the claim record, you'll have the service from date. And the difference between what's the enrollment and disenrollment date and service from date, those can be an important interaction, again, depending on your study. For instance, we have, let's go to the next slide first before I start getting into details, because it might actually be available. So if you require county level data or coverage related specificity, which is about to be where I was going, you're going to want to merge your member records with your medical claim records, and you'd match on the submitting entity, the member ID, birth year, and gender. And then you would look at where the service date is, the service date falling in between the enrollment and disenrollment dates. Now, one drawback to that is that perhaps the submitter didn't update the member record, or perhaps, I mean, this happens a lot. It could even be that the dates of enrollment or disenrollment weren't updated appropriately. So you may have overlap, and you may have to decide which one you're going to use. So just be aware that you might want to check that. So you might do this if you want to evaluate where the member is, like zip code wise or county wise, in relation to the service provider. Like I was saying earlier, you may want to see how far away they might be traveling. And if they move counties, you may want to look at that. There's just a variety of things you can look at. And you can also get some of the demographic information from the enrollment table. And ideally, everything aligns and matches. So my point is that you may not actually have to go to the member table for some of the information that you have. It's just when you want to look at things like county, then you're going to want to pick the records that coincide with the service date and the enrollment dates. Okay. Yep, which is exactly where we were going next. So if you don't need that kind of information, you can use everything that is on the medical claim, which I recommend because it is most likely the most accurate location, like the zip code, because the enrollment table may not be updated with the like a new zip code information. Okay, and
I think that's it. I wanted to add something,
yeah,
Nicole.
yeah.
As well, first I'll support what you just said. So keep in mind that sometimes the enrollment system is different than the medical claim payment system. And so there could be a gap in, or a difference in zip codes or zip 3 or whatever that you have. So don't be surprised if you see it, but don't think that your data is unusable if you see it. The enrollment dates are almost always going to be right. There are times, as Nicole said, when they won't be, but almost always. So just keep that in mind as you look at medical claims data and member data together as you determine your service location or how to use it or whatever. And is that fair, Nicole?
Oh yeah, definitely.
And I want to add one other thing is, because I'm kind of a visual person, though I don't have a slide to describe this, the service provider location comes from the claim form. So if you think about back in the day when you had a paper claim form, and now the systems are built to mimic that, a UBO form or a 1500, there are all sorts of fields in that form that the doctor, the provider fills out and the carrier responds to. And there are specific sections for service provider. And if you're looking at a hospital claim form, attending, and et cetera, et cetera, et cetera. But when I am trying to place where data on a claim comes from and make it contextually relevant, I think of it that way. So those service providers, mostly those service providers are filling out that form. And so the data in there is pretty good. Nothing's 100%, but think about who's filling out the fields into the system from which we get this data.
Right.
All right, Kathy, were there any questions that you saw pop up?
There are no questions in the chat.
Okay, then let's move on. I'm going to take this section. It is one of my favorite things. The section's called How Claims Versioning Affects Users, and we're going to talk about claims versioning. And let's talk about some nomenclature here. Some processes call it updating, some call it adjudication, but in Arkansas APCD, we use the term versioning, and it means to replace an older claim with a newer version of the claim if a change is made. So the oldest data in the APCD, years 13 through 15 or 16 depending, those were final paid claims. We received them late enough that if a change was going to be made, it probably was. Now there's still some out there that, well, now probably not, but it could be that the final version didn't get applied. But by and large, those are final paid claims. But as we move forward, year 17, 18, 19, even now, we've been getting data every quarter all these years, and changes to claims occur. So we consume these in our data submission, and we have to apply them so that you as data requesters and analysts get the latest version of the claim. So that's my intro. You can see on the slide here that changes occur to all the claim, medical, pharmacy, dental, the versions. Each submitting entity, each carrier has its own set of rules to integrate changes with existing claims data, resulting in the final version. And that, of course, is claims versioning. And I'm sorry to say, but some carriers don't version their data at all. And so these are noted in documentation, but and yeah, we worked and worked and worked and were unable to version them, but the percentage of those is very small. If you look at the blue box on the right there, it says only, less than 10% of claims overall require versioning. So ultimately, it's not a lot of data, but it's important nonetheless. So let's move forward. We have a couple of documents that can help you. If you end up with a set of data and you think this is strange, or you find one of those carriers who data, you have some support. So Kathy, if you don't mind, on that first one, let's go over. This takes you to the Arkansas APCD website, and this is the document called APCD Versioning. And let's just scroll down a little. We're not going to read this. I just do want to show you that this document contains some examples, but let's continue some more. The table in here that I want you to be aware of, it's this table right here, and it describes the different types of versioning approaches that we have developed with the carriers to apply to the data. And as you work through a data request and need to understand this, you may see something that's strange. There are some fields that you should ask for on your data request, or you can contact us, tell us which carrier you'll find that in M001 or MC001, and we can help you understand what you're seeing. So Kathy, if you don't mind going back, the Arkansas APCD Data Submission Guide you see in that second bullet, Nicole mentioned that earlier. The Data Submission Guide, for those of you who do not know, that is, for lack of a better description, the rule book that we give to the carriers to give us the data. It is in this book, this document, that they get the rules on how to populate service provider fields, for example. But Kathy, go down to the table of contents. It's a big old thing, and this isn't really designed for data requesters. It's for the carriers to give us data, but an adventurous data requester is welcome to look at it and might find some interesting information. As an aside, I'll say our data dictionary is developed off of this. But so if you'll see there, go down to Exhibit C, I think. Yeah, claims versioning. This is this provides some additional information about some basic versioning approaches and some examples. So this is a resource for you to use as you move forward. Again, do not hesitate to contact Arkansas APCD Tech Support at any questions that you may have. It only makes the process better. So let's go to the next slide. I think that we have some examples. So on there's you saw the table. There are lots of examples, but some common ones are illustrated in these three examples. Approach one, version numbers. If you look at that third column, it's called a version number. A claim, if you go to the doctor and you have 3 things done, It's going to be paid for with a single claim, which is in that first or second column, patient claim control number. There are going to be 3 things charged, 3 different procedures. That's claim line 1, 2, and 3, the line counter. And when it's first submitted, it's all going to have version 0. And then if something happens, if I don't know, a mistake was made or something was overcharged or whatever, you could get an adjustment. If you look at line 5, it's that record is a back out. That means back out to the claim line 1, which is in line 1 above. And then what we would do would replace the record. We would replace record 1 with record 5. So you'd still have claim lines 1, 2, 3. I guess it's on down there, and your claim would be complete. So let's go to the next one, the next approach. Version date. Some carrier systems don't have version number. They have a version date. It's a Julian date. Same principle. We're going to get a new date and a new version of a record with a later date, and we replace it. Let's go on down to the next one. Pharmacy claims. Pharmacy claims generally don't have multiple claim lines. So sometimes you have to group on other things. The member ID and the pharmacy number, fill date perhaps, script number. There are all sorts of ways to group on it. So if you're dealing with pharmacy claims and you're pondering if something looks strange and you think, well, maybe it's the way it's updated, don't hesitate to go to those 2 documents that we had links to and look at it, especially for pharmacy claims. Most of them just replace the claim with a later paid date. Most of them. Okay. So versioning is based on a point in time. If you get a feed from us, that's the latest at that time. A claim, go back.
Where was I? There I am.
There you are. A claim can be versioned more than once and in multiple updates. If 2 things happen to a claim in one submission period, we're going to take the latest one, the final one. But it could be that they get an update in this quarter and then in next quarter. Again, 10%, less than 10% of the time. Data requesters receive the latest version of the claim record, not the oldest records. You saw in that version number example that claim record had been replaced, and we won't send you the old one. We'll send you the new one. In your data sets that you receive from us, duplicate claim lines and claim lines with invalid data are not included in the data. So we found this when we started programming versioning, that carriers will send exact duplicates, byte for byte. And so we eliminate all of that. And then some data has the data within it is too corrupt to send. So those claim lines get flagged and we don't send those to you either. All right, I think let's go to the next slide. That concludes claims versioning at the highest level. Again, don't hesitate to reach out to us to talk about anything that you see with claim versioning. Kathy, are there any questions in the chat?
Nope, I don't have any questions in the chat.
Okay, everyone's saving it up to the end.
Yes,
So the next subject, again, all 3 of these topics we received from users like you submitting suggestions in the survey. And the last subject here, or the next to the last, is talking about grouping diagnosis codes and procedure codes. Let's go to the next slide. So some APCDs throughout the country have groupers. There are all sorts of groupers. But the Arkansas APCD we do not license a grouper at this time. But what we use and have used very well, Nicole can attest to it, is the clinical classification system that was developed by ACHI. And so many of you may already know what this is, and forgive any repetition, but for those of you who don't, well, let me get ahead of myself. So the Arkansas APCD uses this. We have the codes. We don't deliver the codes as part of a data request. We can, though at the end of this, you'll see why. So why we would rather you take it from ACHI. So next slide. I got ahead of myself. Okay. So what the clinical classification system does, CCS, this is just an example. Sometimes a picture speaks 1,000 words, right? So in that first column, those are your ICD-10 diagnosis codes. And what the clinical classification software does is group them logically, if you will. So the CCS code is 234, and all of those ICD-10 codes represent something that's similar. And then the CCS also provides some additional grouping categories, crushing injury or internal injury, a number that is important to CCS, injury and poisoning. I had a lot of fun building this slide because I looked around for something particularly shocking. There were more shocking things to put here, but laceration of posterior tibial artery sounds like it could be very interesting to me. But that's what the clinical classification does. So if your analysis is focused on a specific but broad thing, then you can use this coding to group claims for analytic purposes. Let's go to the next slide. So the CCS codes, they're very handy, and they have ICD-9 codes, 10 codes, and CPT and HCPC codes. If you go out to the ACHI site, you can download the codes yourself. You can download SAS, time-tested, true SAS software that will help you use these. So a moment ago, I got ahead of myself, and I was about to talk about the codes that we have. We do have the codes, and we could put them on the claims. However, we can't provide the software portion of it. So I recommend that you go out to, if you don't have a grouper, then go out and use this software. Download it from the ACHI site, download the data, and it will really enrich your analytics. Nicole, do you have anything to add about CCS codes? You've used them on the APCD data. Put Nicole on the spot. Or Mike, are you out there?
Yeah, this is Mike. Can you hear me?
Yeah.
Yeah, I would just say this is a way that is, for us, readily defined, many thousands of procedure codes and diagnosis codes into workable buckets that most people can understand what that's talking about. And so we've been able to use these to do some county level and state level reporting of utilization, and it's been pretty handy for that purpose. There's multiple levels to it, as Kinley noted, and you can kind of think about it in those terms, but it's something that there's a lot published around it out there in terms of what's in it. So if you haven't ever used it or haven't explored it, it's something that could be a useful tool. It has been for us. So.
It's not a complete proxy for a big, robust, professional, commercial grouper, but it's very effective. All right, let's move to the next. We're in our last portion, the latest APCD release information and data tips. Kathy and I will share this one, so I'll begin. We're going to have an update ready for data requests on August 1st. And it will cover all years 13 through 19. We'll have all the 2019 data in it. That will be an interesting cut. Next slide, please. This is the data that's available. I don't know if we've described it before, but our partner, the Arkansas Department of Health, that provides certain parts of the vital statistics data and the hospital inpatient discharge data, et cetera, they're timely. They provide data once a year, and so their data doesn't change. We'll probably see a change in it in the spring of 2021. But you can see that we are able to advance our Arkansas Medicaid data, our fully commercially insured data, and the workers' compensation data. And we don't have a change in the medical marijuana card holders, but that is forthcoming, although it is still through March 2020, so it's pretty low. Next slide, please. All right, as we manage the data, we find that sometimes carrier data is compromised in some way that we don't include in a release. And we have been working through many problems with Humana and Golden Rule and United C, pharmacy only. And you can see their carrier IDs here. And two that we have managed to resolve are there on the right, United Healthcare B and Guardian data. So those are going to be included in the release that we are going to have on August 1st. And we have a new PBM coming. It's not quite ready, but it should be available probably in the next build, which will be in the fall sometime, and that is Med Impact. So right now we have Caremark, it's a PBM, and we will have Med Impact. So we're excited about that. Next slide. Some data tips. So always remember to utilize the searchable APCD resources, the data dictionaries, and the tip sheets. Before we go, Kathy, I'm going to ask you to click on tip sheets. Wait, don't do it yet. Let me see. Actually, do click on tip sheets, and then why don't you added something, a function, Kathy. Why don't you describe that?
Sure. If you've been to the tip sheet before, you will probably have noticed the new change. So data issues, data tips, and resolved issues are each in their own table. But I have updated the functionality on them. Each table is now searchable. You can scroll through the whole table. You don't have to switch pages anymore. You can search on each of these fields. Active versus resolved, for instance, is a drop down. So if you got data, or if you get data after January 20th, all of these issues are now resolved. Let's see if,
Here, I'm going to give you a test.
okay.
Search for Arkansas Medicare.
Okay, hang on.
All right.
I'm having an issue. This is new, so let's do that. There we go. Say it again.
This is a data tip, and it's
Okay.
Arkansas Medicare. Just search on those words. There it is. Very
There it
good.
is. Right at the top. There you go. Anyway, if I put Medicare in here, then you'll get the one that says Medicare and then also one that talks about Medicare.
Right. And I wanted to point this out because we received a question from a data user about calculating payment amounts in fee-for-service and DME claims, and we reached out to ResDAC for an answer, and they provided a usable answer, so we posted it here because I'm sure not everyone is eligible to get Medicare data, but those who are might find it useful. Another tip that I want to point out is 95442. Look up EBD or 99EBD1.
Is that a tip?
Yeah. I think it's a tip. Yeah. So EBD is the Arkansas Employee Benefits Division, and it utilizes some TPAs, third-party administrators. And some of that TPA data is present in the private carrier. So QualChoice and Blue Cross Blue Shield are the TPAs. So if you're using this EBD data, it's important to look at that and make certain that you're not, and frankly, pulling double claims. And this information will help you exclude the TPA data. We recommend that at this point in time you use the EBD data that is sourced, that has 99 EBD1 as the submitter and not the TPA data. There are a couple of other, let's see, look up 79413B, Kathy. B.
B?
B is in boy.
That must not be a tip. Hang on.
Oh, it may be.
I think I'm gonna put these together.
Okay.
79413B.
Uh-huh. Okay. Okay, so does this say resolved? Yeah. So in this data, in this particular carrier, 79413B, I think it's a United carrier. Early on, they were putting their member ID in the wrong field, ME009. That is now resolved. It is in the correct field, but if you have data that from this particular carrier, you might pay attention to that if you're looking for a member ID. All right. So are there any questions about the tip sheet? Okay.
I would like to say that if you go to the data dictionaries and you go to the data elements, the same filtering capability has been added to those pages as well.
Great. Very good. The last bullet coming soon, we have recently learned that entity 80799, which is Centene or Celtic, has acquired part of the Qual Choice exchange plans, and rules are forthcoming on how to identify the change in the member. We don't have the data yet, so that will make you aware of that change, and so that you can be able to segment appropriately in your data. Okay, so I say to all data requesters and data users, don't forget to check your issue steps for the latest information. There's a wealth of information there. We keep up as we can. And please let us know. Are any questions?
Kenley, you were cutting out really bad. You were cutting out really bad.
Oh, I was? Okay.
Start this slide all over.
Okay, I'll do this slide over. Don't forget to always check the APCD data issue and tip sheets page. We do our best to keep it updated with everything that we see. If there's a wealth of information that will probably save you a lot of heartache. And if you find something that's not out there, please let us know. And if you find that our explanation is not understandable, please let us know and we will fix it. Is that better?
Yes.
Okay. All right.
Okay. And so we are ready for questions.
Yes.
You can type them in the chat, or you can raise your hand. And I've lost my participants. Where did they go? Here they are. I have one with his hand raised. Okay. Steve Wild. Go ahead, sir.
Yeah, thank you. And hi, everybody. So I work with an organization called Healthy Price. We're working on price transparency, and we're up in the New England area and thinking about Arkansas and all the great work being done there. And one question I have is, how does your organization decide to exclude a pair entirely for issues versus just kind of noting the nuances in their submissions? How strict are you?
That is a terrific question. The primary reason we exclude a pair is because they have there's something wrong with their member ID, and that there is no way that the data can be used to associate anything with a particular member. We also have a field called a hash ID, and that represents the individual at the last name, date of birth level. And if a carrier has messed up, has made mistakes or something, there's something wrong with their hash ID, we will most often exclude that as well. There are very few other things that will occur to exclude a carrier.
Okay.
Thank you.
You're welcome.
Very good. We have one question on chat.
Yep.
CCS, has it been straightforward to run the AR APCD claims through CCS, or are there any tips and lessons you can share regarding implementation?
What a great question. So Mr. Motley and Nicole, are you still out there?
I think Nicole wants to say something.
Okay.
You're muted. Hang on, I have to find you. Or you can unmute yourself. Not yet. Here you are. No? We still can't hear you.
This is Mike. I can take a first pass, and then while Nicole tries to get on. Oh,
Okay.
Wait, can you hear me now?
Go ahead,
Yeah.
Nicole.
I think the problem was there's two of me, a computer one and a phone one. Yeah, actually, that is pretty straightforward, but you have to be aware that if you're using it for diagnosis codes, you have the ICD-10 codes and the ICD-9 codes, and there's actually some overlap between ICD-9 and ICD-10. And those are E codes, which in ICD-9 are emergency codes, and then in ICD-10 they are diabetes and endocrinology types of codes. And there's also V codes, which I think in ICD-9 are visit codes, and ICD-10 are like vehicular accident codes. So in both submitters, we have both ICD-9 and ICD-10 in the APCD, but there's also a flag in there that will tell you which one to use. So when you are grouping by CCS codes for diagnosis codes, you need to pay attention to which one you're using, 9 or 10.
Right. So Nicole and the person who asked the question, there are two fields, as Nicole described, MC915D and MC915P. There's an overall one, but we'll talk about those two. The D stands for diagnosis and the P stands for procedure. And the intent of these codes, these fields, is to tell you if the code is ICD-9 only, ICD-10 only, or the overlap as Nicole describes. It's just a flag.
Okay. We got a message from Claire. She appreciates the tip sheet and additions and interactivity. Thank you, Claire. We try. I don't see any other hands up, and I don't see any other questions. Have I missed anybody? Okay. Any final comments, Kinley?
Thank you all. You make this data set, this database, more valuable with all of your interaction. This isn't a pitch to complete the survey, though I wish you would complete the survey. That you will receive an email at the end of this, or probably by the end of the day, to get some feedback. We are looking for subjects. Don't hesitate to reach out to Arkansas APCD technical support. It will be in the email that you receive, or just go to the website. And you make us better, and we appreciate it. That'll do it.
All right. Thank you, everybody.
Thanks, everyone.
Thanks.